So good evening, everyone. So I thank the organizers of the ISRTP pathology group for inviting me to contribute to this topic, that is thrombotic microangiopathy in the renal allograft biopsies. So over next half an hour, I'll be speaking on this topic, and it is a very important topic for the renal transplant recipients, patients who undergo renal transplantation. It is a relatively a rare complication as compared to the rejections or ATNs, but it is of very practical value and very important for the transplant physicians to know about this topic. So what is thrombotic microangiopathy? So thrombotic microangiopathy basically is a disease which is characterized by endothelial dysfunction and presence of thrombi in the smaller blood vessels. It is a life-threatening disease, and when the vessels get occluded, it causes tissue ischemia, and there is organ damage, and it can affect primarily the kidneys. That's why we have renal failure in these patients, although it can affect other organ systems as well. And during this process, there is a platelet consumption and mechanical disturbance of red blood cells, and that's why we have thrombocytopenia and microangiopathic hemolytic anemia in these patients. So these patients will have a triad of microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. Now, what is the pathogenic classification of thrombotic microangiopathy? So we can have a primary TMA syndromes, which can be in the form of TTP or due to ADAMTS30 deficiency, or typical hemolytic uremic syndrome caused by Shiga toxin producing E. coli, or atypical hemolytic uremic syndromes. We can have the second category, the secondary TMA syndromes, which can be seen secondary to infections like viral infections, fungal infections in patients with organ transplant, both solid organ transplants and hematopoietic stem cell transplantation, due to drugs, which can be in the form of cancer chemotherapy drugs, VEGF inhibitor drugs, immunosuppressants as received by transplant patients, which can be in the form of calcineurin inhibitors, what we call as CNIs, in the form of tacrolimus and cyclosporine, or mammalian target of rapamycin inhibitors, which we call mTOR inhibitors, example everolimus and sirolimus, secondary to malignancies, pregnancy, and autoimmune diseases. So in general, this is the pathogenic classification of thrombotic microangiopathy. But today we are talking about thrombotic microangiopathy in the renal allograft recipients. So thrombotic microangiopathy in renal transplantation is a rare phenomena, but it is a very serious complication which affects the kidney in transplant patients. The reported incidence is 0.8 to 14% of all the transplanted patients. And this condition negatively affects both the graft as well as the patient survival. Now, the post-transplant TMA can be either in the form of de novo TMA, which is far more common and accounts for 80 to 90% of the thrombotic microangiopathy seen in the renal transplant recipients, or it could be in the form of a recurrent atypical hemolytic uremic syndrome, which accounts for about 10 to 20% of the TMAs which we see in the post-transplant settings. Now, causes of post-transplant thrombotic microangiopathy, as I told you in the previous slide, it can be because of the complement protein mutations which result in atypical hemolytic uremic syndrome, or it could be de novo post-transplant thrombotic microangiopathy, or what we also call as secondary atypical HUS, because these patients, in addition to the precipitating agent, about 30% of these patients may harbor some complement protein mutations. So the causes of de novo post-transplant TMA are related to donor type and organ procurement process, that is, in patients with the diseased brain dead donor and cardiac dead donors, or due to ischemic reperfusion injury. It could be associated to the post-transplant events due to drugs like calcineurin inhibitors, in which cyclosporin and tacrolimus are implicated. Cyclosporin more than tacrolimus due to mTOR inhibitor drugs. It could be seen because of the complication of the acute antibody-mediated rejection. It can be seen in several infections, including viral infections like cytomegalovirus, parvovirus, Nile fever virus, or due to fungi. Antiphospholipid antibody syndrome has also been implicated in the post-transplant TMAs. Other causes of TMA not related to kidney transplantation include pregnancy and other drugs like anti-VEGF, gemcitabine, etc. Now, as I've already told you that de novo thrombotic microangiopathy accounts for 80 to 90% cases of the post-transplant TMA. So it is far more common as compared to the recurrent TMAs. It is related to the type of donor and organ procurement, as I have already discussed, due to the post-transplant events like drugs, ABMR infection, which also I have already told you in the previous slide, and other causes which are not related to the transplant. Now, recurrent TMA or the recurrent atypical hemolytic uremic syndrome is caused by the complement protein mutations resulting in atypical hemolytic uremic syndromes. So these patients harbor various forms of complement protein mutation, which I will be just enlisting, and depending upon the type of complement protein mutations, they will be either high risk for developing of the recurrent atypical HUS or moderate risk or low risk. So patients who have got a mutation in the complement factor H, so pathogenic mutation in the complement factor H carries a very high risk of recurrence, more than 80% recurrence rate, followed by complement factor B mutations. Moderate risk, that is 40 to 75% recurrence rate, can be seen because of isolated complement factor I mutations or C3 mutations or detection or detectable circulating anti-factor H antibodies. In other conditions like MCP, membrane cofactor protein mutation, diglycerol kinase mutations, or absence of anti-complement factor H antibodies, the recurrence rate is very low. So this is the table just to show you the mutation frequency in patients with atypical HUS of various complement factor proteins and the risk of recurrence after transplantation. So the maximum mutation is seen in the complement factor H, and also this carries the highest recurrence rate after transplantation, followed by complement factor B, complement factor I, C3, and least with the MCP, that is membrane cofactor protein. Now, it has been shown by studies that use of prophylactic eculizumab can reduce the post-transplant recurrent rate of TMA from 49 to 12% in patients with the atypical hemolytic uremic syndrome. And by giving prophylactic eculizumab, it will reduce the probability of graft loss in these patients, and also it will allow significant increase in the number of patients who have atypical HUS to undergo a kidney transplantation. Now, what is the timing of occurrence of post-transplant TMA? So, TMA can occur in the post-transplant setting virtually at any time, but most commonly seen during the first 3 months after transplantation. As we know that during these first 3 months, there is presence of more complement activating events like ischemic reperfusion injury, presence of high immunosuppression during this period of time, high risk of infections, and episodes of acute antibody-mediated reactions also higher during this time. So during the first 3 months, there is a high chance of developing TMA. Systemic TMAs usually appear in the early post-transplant period. By systemic TMA, I mean the TMA which involves the kidney as well as the other organ systems, whereas the localized form of TMA can occur anytime after the transplantation. Now, what are the various clinical manifestations of post-transplant TMA? So, clinical manifestations can be in the systemic form, which accounts for 18 to 62% patients, and they will have microangiopathic hemolytic anemias, thrombocytopenia, increase in the serum LDH level, reduced heptoglobulin levels, and schistocyte formation and renal failure. Or it could be in the localized form, in which they will be isolated acute kidney injury, or as a chronic form with slowly progressive graft dysfunction, proteinuria, or arterial hypertension. Now, coming on to the renal histomorphological changes which we see in patients with TMA. So, in the acute or the active form of the disease, there will be intraluminal fibrin occlusive thrombi within the glomerular capillary loops, accompanied by endothelial cell swelling. We can see fragmented red blood cells in the capillaries, mesangiolisis and microaneurysms, presence of myocyte necrosis and intramural fibrin in the arterioles. On immunofluorescence, there is negative complement or immunoglobulin, so there is no deposit of complement or immunoglobulin. But fibrin deposition can be seen in the vessel walls. On electron microscopy, we can see presence of subendothelial widening by floccular material, or what we call as subendothelial fluff. In the chronic phase, we can see double contour formation in the peripheral glomerular capillary walls, hyaline deposit in the arterioles, and fibrous intimal thickening with concentric lamination may also be seen. On electron microscopy, we can see new subendothelial base membrane and widening of the subendothelial zone. So this is in general feature of histomorphological feature of post-transplant TMA. Now here in this slide we can see two microphotographs. The one on the left, we can see presence of fibrin thrombi within the glomerular capillary loop and congested glomerular capillary loops in the surrounding. In the right side, we can see presence of fibrillary appearance of the mesangium with solidified appearance of the glomerular capillary tuft and embedded red blood cells and fibrin within the mesangium, and presence of mesangiolisis. In this slide, we can see presence of numerous fibrin thrombi within the glomerular capillary loops, and on the right we can see presence of double contour appearance of the GBM, and this is a chronic TMA morphology. So why biopsy is important in patient with post-transplant TMA? So we need to do biopsy to find out any acute injury in the biopsy, and together with the clinical and laboratory data, it can lead us to suspect the TMA activity and the need for giving active treatment to the patient. Now, this is in general morphology of TMA. So the question is, can we have certain diagnostic clues for etiology? Yes, we can have. So in the form of personal or family history, abrupt onset, systemic extrarenal manifestations, then this would favor more in patients of recurrent atypical HUS as compared to de novo TMA. So these findings will favor more TMA due to a recurrent atypical HUS. On renal allograft biopsies, do we have a clue? Yes. So if the patient has C4D deposits or peritubular capillitis and glomerulitis, it will favor ABMR as a cause of TMA. If we are able to see isometric vascularization in the renal tubules, regeneration of the smooth muscle of the vessels, then this will suggest acute CNA toxicity. So we can have clues from the history, the lab, and the biopsy as well, which can point towards the etiology of the post-transplant TMA. Now it is very important that after the diagnosis of TMA is made, the etiology of the native kidney ESRD should always be investigated to rule out a previously missed atypical hemolytic uremic syndrome. So we should always try to exclude atypical hemolytic uremic syndrome which has recurred before giving other possibilities of TMA in the post-transplant setting. Now, what are the various laboratory tests which can be performed for post-transplant TMA? So to identify that TMA is going on, we can do testing for anemia, thrombocytopenia, to look for schistocytes, LDH levels, and heptoglobin levels. To rule out TTP, we can see ADAMTS activity, and then to look for cobalamin deficiencies. To look for the sugar toxin associated HUS, we can use stool culture for E. coli. Then we have to look at the levels of the various drugs like the cyclosporine and the tacrolimus, and we can also look for infections by doing PCRs and the serological assays. And then we can do TSA to look for presence of class 1 or class 2 anti-HLA antibodies if we are suspecting ABMR as a cause of thrombotic microangiopathy. So along with biopsy, we can use the various battery of the tests to find out the cause of TMA. So what is the prognosis in post-transplant TMA? So this TMA is associated with poor graft survival. So it has been shown by studies that overall graft loss rate of about 33 to 40% in the first 2 years. In recurrent atypical HUS, 90% graft loss is seen in the first year in the pre-eculizumab era. What about the patient survival? So there is 97% 1 year patient survival, but it drops to 50% when we look at the 3 year patient survival. So both the graft and patient survival are adversely affected by presence of post-transplant thrombotic microangiopathy. So poorer short-term graft survival has been described in patients with systemic form of post-transplant TMA, reflecting a more severe disease with higher incidence of dialysis-dependent AKI and requirement of plasma exchange. The prognosis in long term is similar in cases of both the systemic TMA and the localized form. The prognosis is also similar in both the early and the late manifestation of post-transplant TMA. That is, patient who present early, less than 3 months, versus those who present late. The overall prognosis is relatively similar in both the groups. Now, certain Indian studies, I would like to quote one study from Hyderabad, published about 10 years before, in which they found TMA in 12 of their 131 graft biopsy performed between 2010 and 12. And of this, the majority were the de novo TMA, including 5 cases of CNA toxicity, 1 case of sirolimus toxicity, 3 cases of ABMR, 1 case of CMV, and there were only 2 cases of recurrent atypical hemolytic uremic syndrome. And the duration of presentation after transplantation ranged from as early as 2 days to as long as 10 months after transplantation. Now, another study from SGPGI, in which they found TMA in 17 out of 2000 transplants done between 1989 and 2015. All patients had de novo TMA, out of which 5 had ABMR and 12 were cases of CNA toxicity. There were no reported cases of recurrent atypical HUS in this study. The duration of presentation after transplantation ranged from 1 month post-transplant to as long as 168 months post-transplant. And systemic evidence of hemolysis was noted only in 4 of the 17 patients. Now, this is data from our own hospital. So from 2017 to June 2022, so out of the 480 graft biopsies, 10 cases had thrombotic microangiopathy. So 1 case was recurrent atypical HUS, rest 9 were de novo thrombotic microangiopathies, of which 5 were cases of acute antibody-mediated rejection associated TMAs, and there were 4 cases of acute CNA toxicity induced TMA. And timing of occurrence, all the cases occur within 3 months from the date of transplantation. Now, what is the recommended treatment? So although this is not my domain, still I would like to touch a little bit on the treatment of atypical hemolytic uremic syndrome recurrence. So it can be prophylactic treatment or recurrent treatment for recurrence. So the prophylactic treatment is with the plasmapheresis, and it has been shown that it does not effectively prevent recurrence in patients with high or moderate risk mutation. So plasmapheresis is not very effective. However, good results have been seen with the eculizumab as the first line therapy. And in the treatment of recurrence, plasmapheresis has little success, and good results have been seen with the early introduction of the eculizumab therapy. So this is just to show you the this chart in which we talk about the prophylaxis against atypical hemolytic uremic syndrome recurrence in the allograft based on their risk assessment strategy. So they say the patients who are at higher risk, they should have they should receive prophylactic eclumbab, and it should be started on the day of transplantation due to the potential for severe recurrence. In patients who are at moderate risk, and then these patients should also receive a prophylactic eclumbab or plasma exchange before undergoing transplantation. And in patients who are at low risk, that is isolated membrane cofactor protein mutations or persistently negative anti-factor H antibodies, these patients require no prophylaxis. Now, what is the treatment of de novo post-transplant TMA? So it is based on correcting the potential cause of the disease, that is removal of the offending agent. So belatacept, which inhibits T cell function, allows minimization or discontinuation of the endothelial toxic immunosuppressants such as CNIs and mTOR inhibitors. There is a role of eculizumab in the management of the resistant medication associated TMAs. In ABMR associated TMA, the mainstay of treatment is IV IgG and additional immunosuppression. So let's look at a few of the representative cases. So case 1 is a 51-year-old male patient, known case of bilateral renal calculus disease, and the patient was asymptomatic for 6 to 7 years with a nadir serum creatinine of 1.2. Thereafter, there was a slow rise in the creatinine to 3, biocytopenia with hemoglobin and platelet of 7.2 gram and 84,000 respectively, and cystocyte index of 4.2%. Kidney biopsy was done at another center, which was reported as TMA. Plex was started until the platelet, LDH, and cystocyte index improved. And he was on maintenance hemodialysis twice a week due to the irrecoverable kidney failure. Subsequently, he underwent ABO-compatible kidney transplant at another center, that is in February 2022. The donor was sister, and induction was with thymoglobulin, and patient was discharged with a creatinine of 1 milligram per deciliter. After 4 weeks, he was admitted to our hospital in March 22 with complaints of worsening allograft function. So on investigation, patient had anemia with low platelet, 1 lakh, and our serum creatinine was 3 milligram per deciliter, sodium 138, potassium 5.96, urine routine showed protein 2 plus, numerous RBCs, and 10 to 15 WBCs per high power field. The tacrolimus level was 8 picogram per deciliter. So kidney biopsy was done. So this is a low power view of kidney biopsy showing you several glomeruli, and many of these glomeruli at this part only you can see presence of these fibrin thrombi, which is plugging the glomerular capillaries. We can see hardly any interstitial inflammation in the background. Again, several other fields showing presence of fibrin thrombi occluding the glomerular capillary loops, large thrombi occluding the glomerular capillary loops, no significant inflammation in any compartment. Again, this photomicrograph is to show you the tubular interstitial compartment. So we cannot see any tubulitis, any peritubular capillitis, any interstitial inflammation, any viral inclusions. And on empty stain, we can again see empty stain highlights the numerous presence of these fibrin thrombi within the glomerular capillary loops. So the kidney biopsy morphological diagnosis was thrombotic microangiopathy. His genetic workup was done for recurrent TMA, and whole exome sequence it showed mutation in the complement factor H gene. So Plex was continued till the hematological remission was achieved, and the patient is now dialysis dependent. So this was a case of a recurrent atypical HUS in the post-transplant setting. Now case number 2, 31-year-old female, known case of renal allograft recipient in May 22, basic disease IgA nephropathy. Patient had stable graft function with a creatinine of 1.1, and patient was admitted with rising serum creatinine. On investigation, found to have a creatinine of 1.74, hemoglobin of 8.9, TLC 10,000, and platelet of 1.2 lakh. The tract levels were 17.2. In view of the rising creatinine and worsening of the hematological profile, ultrasound-guided kidney biopsy was done under the platelet cover with a clinical suspicion of TMA. So this biopsy, again we can see this low power view, presence of beautiful fibrillary thrombi occluding the glomerular capillary loops. Again in this biopsy, we can hardly see any inflammation. So there is no tubulitis, glomerulitis or perotubular capillaritis. So there is no inflammation in the background. Again, this field we can see a thrombus occluding the glomerular capillary loop, minimal focal interstitial inflammation. Otherwise, rest of the biopsy looks good. And in this field, we can see tubules with presence of numerous small equal-sized vacuoles, what we call as isometric vacuoles. Again, in this field, we can see presence of these numerous isometric vacuoles within the cytoplasm of the tubular epithelial cells. So this gives a diagnostic clue that it could be due to a CNI toxicity. And as we have seen in the previous slide, the levels of the CNI was quite high. C4D was negative in this case. So there was negative C4D in the perotubular capillaries. So this biopsy revealed presence of acute CNI toxicity with manifestation of thrombotic microangiopathy. So in this patient, the CNI was stopped and the immunosuppressive therapy was modified accordingly. Now the case number 3 is a 31-year-old female, known case of renal allograft recipient in December 21, presented with complaints of fever, body ache for 8 to 10 days, and patient presented 2 months after the transplant. On evaluation, she was found to have COVID-19 disease, for which she was admitted outside in a private hospital and managed conservatively. Later, after 2 weeks, presented to our hospital with deranged renal function, a creatinine of 7.85 milligram per deciliter. On admission, hemoglobin was 6.8, total count 18,000, platelets 31,000, urine routine microscopy showed protein nil, RBCs 5 to 6, WBT 6 to 8, and 10 to 20 epithelial cells per field. Cystocyte index was 2.4%. Ultrasound graft Doppler was done, which revealed a resistive index of 0.8 and raised cortical echogenicity. Patient received intermittent sessions of hemodialysis along with platelet transfusion as per the requirement. In view of suspicion of the TMA, she underwent plasma exchange 4 sessions followed by IVIG. After stabilization, patient underwent a renal biopsy. Now, as compared to the previous 2 biopsy, here we can see the presence of inflammation in the perotubular capillaries, that is perotubular capillaritis, marked perotubular capillary congestion. Within the glomeruli also, we can see presence of glomerulitis, and there is occluding thrombi within the glomerular capillary loops. Again, in this field, we can see markedly congested glomerulus with loss of cellular details, perotubular capillaritis in the background, few tubules which are showing necrotic changes. Again, this field showing you necrotic changes within the lining epithelium of the tubules, presence of perotubular capillaritis, and presence of fibrillary necrosis in the wall of the artery and arteriole. C4D was diffusely positive in the perotubular capillaries. So this was a case of TMA secondary to acute antibody mediated rejection. Now to conclude, thrombotic microangiopathy is an uncommon but life-threatening disease in the post-transplant setting, which has a poor patient and graft survival. De novo TMAs are much more common as compared to recurrent thrombotic microangiopathies. Whenever post-transplant thrombotic microangiopathy is seen, always we should investigate the cause of native ESRD to exclude the possibility of missed atypical hemolytic uremic syndrome. it is very important both on the part of the transplant physicians and the renal pathologist to be aware of this entity and the finer nuances of this entity so that it can be timely diagnosed and so that the effective patient management can be done and both the graft and the patient life can be prolonged. So thank you very much, and I would be available to take any questions. Thanks a lot.
Thank you, sir. Thank you for this lucid presentation. Along with this clinical scenario, you explained very well. This TMA due to recurrent HUS, then we have to investigate ESRD for the patient, and also due to CNI toxicity and antibody-mediated rejection. Thank you very much. Yeah, one question is there, sir. So what
Yeah.
prevention, what prevention can be taken to avoid post-transplant TMA? So
Yes,
I
yes.
just mentioned, you can add
So
on that.
I have already mentioned
Yes,
in
sir.
the slides. So 2-3 points I will like to repeat.
Yes, sir.
One is that endothelial, any event which causes endothelial injury, which leads to complement activation, like ischemic reperfusion injuries, viral infections, CNIs. So all these factors will cause endothelial injury and thereby leading to complement activation. So these should be avoided. Second is plasmapheresis. So in atypical HUS, if you have got low risk mutations, so plasmapheresis can be done, or even in cases of moderate to high risk mutation, that is complement factor H and I mutation, complement factor B mutation, there is a role of eculizumab, which has been shown in the slides during the presentation. So these are the various factors which can help in prevention of the TMA in the post-transplant settings.
Yes, sir. Yeah, that's all. And I thought you had gone for this frozen, so I apologized for you were not there for a couple of minutes. Uh, so glad that you answered that question, sir. And so if we are not, as you said, sir, this ESRD workup should be done. So like if any diagnosed TMA is there, so for that,
Yeah.
every case for native kidney also, you go for this
So actually, I'm still.
genome sequencing and also.
Yeah, you were asking something, Dr. Radhika?
Sir, for any diagnosed TMA, would you advise as a renal pathologist to go for this genome sequencing?
Yeah.
Okay, sir.
So I already told that in the post, and we have unknown cause of ESRD. So we have no known cause of ESRD in the pre-transplant setting. Then we should always try and search for any complement mutations, and thereafter only we should label the patient as de novo TMA, because even in 30 to 40% cases of de novo TMA, it has been found that they harbor some form of complement mutations. So they are not just pure de novo TMS, they are actually the inciting events. So ABMR, CNI toxicity, viral infection, they are inciting events. So 30 to 40% of these patients already harbor mutation in the alternate complement pathway. They have got complement factor mutations, but these events are inciting events. So I would recommend that all the patients of post-transplant TMA should undergo a minimum panel of complement factor mutation testing, which should include complement factor H, complement factor I, complement factor B, C3 mutations, MCP, that is membrane cofactor protein, and diglycerol kinase mutations. So these mutations, no, if not whole exome sequencing, at least these mutations should be looked at in the setting of post-transplant TMA. Why is it important? Is for prognosis.
Sure, sir. Next question is there any means by which we can suspect TMA recurrence in pre-transplant end-stage renal disease biopsy?
Yeah, so see, so if the patient has already reached ASRD, the manifestation which we can see in the biopsies of chronic TMA, that is double contour appearance of the GBM
Yes, sir.
and arteriosclerosis, fibrointimal thickening of the blood vessels, onion skin appearance.
And
We will not be
yes.
able to see thrombi, fibrin thrombi, or any acute events in the biopsy. Okay, so but these findings are non-specific. So double contour appearance, so myointimal fibrosis, or onion skinning are non-specific changes. We can just say that patient may have TMA, patient may have hypertensive changes, but we cannot, with the chronic changes only, we cannot just pinpoint that patient might be having TMA. Okay, but yes, if we have got any hematological manifestation in the form of anemia, thrombocytopenia, or schistocyte, we can suspect, yes, that patient might be having these manifestations because of TMA. And then we should do further workup, laboratory workup, as already suggested in the during
Yes.
the webinar.
Yes, sir. Yes, thank you. Thank you, sir. I think that's all. And if any questions come, then I will direct them to you. They can send you
Sure.
email and ask.
Sure.
Thank you.
Thank you so much.
Thank you,
Thank you so much.
Anjali.
Thank you.
Thank you, I sought.
Thank you. Thank you.
Good.